All right, well, welcome. I want to take a minute. This is Craig Manifold and talk to you about our data from our 2017 cardiac arrest review. Now, this is primarily data from our transport agencies, but one of the things I'd like to do is share with you also our first responder organization information. And what we've done is we've gone ahead and we have taken our 2017 cardiac arrest that are primarily medical arrests. We've excluded the traumatic arrest, and we're comparing them to a national database called CARES, which is a cardiac arrest registry. And what you'll do is you'll see that we had in 2017, our transport agencies have recorded 60 cardiac arrests compared to 76,000 patients in the CARES registry. And what we want to do is look at a few of those numbers so we can understand them a little bit better. The first is we look at witness versus unwitnessed arrest, and we can see that when we compare this to our national registry, the CARES data, that we're a little bit different. We've had 33 versus 48% witness arrest and unwitnessed arrest, approximately 70 versus 50%. So a few changes or differences that we see there. When we look at shockable rhythms and non-shockable initial rhythms, that most of the time we're looking pretty comparable to the CARES registry of 20% versus 20, 80 versus 80. And our average age for these patients was 62 in the CARES registry versus almost 60 and a half for us. We looked at our average time to first shock as well, and that was approximately 2.5 minutes, as well as our time to first epidose, which was almost 6 minutes with that. So this gives us some areas and things that we can improve upon as well. Our first look at this information looked at some of the interventions that were performed and things, and what I'd like to do is kind of orient you to the graph. We have 0 through 100%, and we have blue represents the Office of the Medical Director, or again, our transport agencies, and CARES is in red, which is the national database and things. And so we compared these in our percentages to help us kind of understand that particular type of information and things as it come along. And so this first category, we look at bystander CPR, which is one of the areas where we did a little bit better in our comparison to the national benchmark. Public access defibrillation, again, a little bit better as well of our agencies versus the registry. And then the Lucas device and the ITD, or impedance threshold device, is not recorded in the national database. But we wanted to look at our utilization, and we can see that a number of our agencies are using the Lucas device, and then less than 20% are actually using the impedance thoracic device. And then we also have started in our area looking at 30-degree head of elevation or head elevation during CPR, and that's usually better to be performed when we're using mechanical CPR as well as the ITD. And so we wanted to look at those numbers, and again, this is relatively small at this point in time, and we'll continue to grow that. TTM is targeted temperature management, or what we used to call hypothermia, therapeutic hypothermia, and we're doing a little bit better in that area. As you remember, over the last couple of years, there's been less emphasis on targeted temperature management in the pre-hospital field. What we found, though, is, from my perspective, although it's not necessarily required to do in the pre-hospital environment, when we initiate it in the pre-hospital environment, more and more hospitals will do that, and we're working in the region to start to develop resuscitation centers, and this is one of the areas that we'll look at that and see if we can improve these particular sets of numbers. And again, patients who undergo therapeutic hypothermia or targeted temperature management actually have improved neurologic survival. The problem is, or the issue is there's not necessarily a added benefit by starting it in the hospital, or in the pre-hospital environment, other than that continues on in the hospital if we initiate it in the field. We're going to again look at our overall data, looking at our transport agencies first. And so what I'd like you to do is take a look at each of the individual agencies that are out there, and we're going to orient to the slide again. The yellow line this time is our CARES data. The red line is the Office of the Medical Director, and these would be kind of our national, our yellow line is our national benchmark. The red line is the Office of the Medical Director or our transport agencies, how well they've done in this particular agency and by agency. Now, you can see that we have not identified each of the agencies, and that's because this is really the first time we're looking at it and we're sharing it in a more public manner. And so what I want to do to you, let you know, is you can look by agency and make some generalizations for that. And so again, when we look at this particular first agent, we can see that that meets the CARES benchmark, and we can see when it comes to the overall sustained ROSC rates that we see. So sustained ROSC is return of spontaneous circulation that's more than just a few seconds or a minute. That this means that we've had a patient who has been able to establish a return of spontaneous circulation and maintain that for a few minutes. And so then we have a different agency here who had over 50% of those patients in cardiac arrest included in the database who had 50% or so, 5 out of 10 of those patients with sustained ROSC. Here's an agency where didn't do quite as well with only about 11% of the patients with sustained ROSC, and so on and so forth. And so again, we can see these individual agencies and how they compare, but our overall data looks at the CARES data with the yellow line and our clinical transport agencies with the red line overall. This looks at survival to hospital admission. This means the patients were brought to the emergency department, their resuscitation was continued, they survived through the emergency department resuscitation and were admitted to the hospital. And so again, we can see by individual agency, we can compare to the CARES data versus our Office of the Medical Director information and data that's provided. So again, great numbers and information that we're able to provide, but we can see a couple of our agencies have some work to do. And the difficulty is, again, when we look at the numbers, they're such small numbers, one change in one direction or the other can make a tremendous difference. And so that's why, again, you have to work so hard at these medical resuscitation patients in order to improve your resuscitation rates. Utstein survival, as some people may have heard of, is kind of the best of all conditions. In other words, bystander CPR was initiated, it was a witness cardiac arrest, and when we arrived on scene, it was an initially shockable rhythm that was identified. And so with that, we'll look at these and remember some of the best Utstein survival rates reported in the nation can hover around 50% or so, and so those are areas that we want to emulate and try and do our best for that. And you can see in this particular category, again, with these relatively small numbers of sustained ROSC in the Utstein criteria, so we were able to outperform over the national average or benchmark from 77% to 53%. So again, these are great numbers that we have are available for us in these Utstein type of patients, or again, the patient with bystander CPR, a witness cardiac arrest, and an initial shockable rhythm. Next, we look at survival to hospital admission, which we talked about before in this subset of patients who have bystander CPR, witness arrest, and initial shockable rhythm. And you can see again that we've done very well with these particular patients, and these are folks who have gone on to do well when they go home with a hospital discharge with what's called a CPC, or Cerebral Performance Category 1 or 2 in these Utstein criteria. And so what we've been able to do is, again, share our numbers, particularly for these three agencies who've been able to send somebody home with a CPC score of 1 or 2. And what that means is, again, that that patient has been able to go home and function essentially well in their home environment. And so these are the folks that go home or discharge and do really well. And you can see where we have outperformed with our transport agencies of up to close to 67% versus only 30% versus the national benchmark. So again, kudos to these great folks and the work that's been done by these agencies to get these folks resuscitated and get them on home. Now, when we start to go back and look at what things help and really make a difference in being able to resuscitate these patients, well, what that boils down to are what we're calling the survivability factors. And there's not really major surprises to this, but when we go back and we look at our data, with patients who are going or discharged home with a CPC 1 or 2, what we can see is if it's a witnessed arrest, they have bystander CPR, and it's an initial shockable rhythm, those are things that are associated with better survival. Just like the Utstein criteria, again, it's the best opportunity for those patients to go home and be able to function well. And so we like to work with all of the new advances in cardiac arrest management. Dr. Abraham and I are very supportive of those things. But when we look at those and where we can best spend our resources and our efforts, it's really looking at these particular areas to, again, address bystander CPR and increase our rates of bystander CPR with CPR, dispatch assisted CPR, and again, getting a defibrillator to the patient's side quickly and effectively defibrillate that patient for us. So those are the particular areas that we see and, again, want to concentrate on. On our first responder agencies, we're still trying to work on collecting the data. We didn't have nearly as robust information for our first responder agencies at this particular time, but we wanted to share a little bit of information with that because our first responders are critically important to. And then when we look at sustained ROSC, again, which is return of spontaneous circulation, which is really our marker in the field, and it's our first step in getting these patients resuscitated and stabilized, we can see that our first responder organizations had about 23% of their patients who had sustained ROSC as compared to the transport agencies and then compared to our national average. So it identifies and highlights that we've got a significant amount of work to do looking at not only documenting and recording the information, but again, improving our cardiac arrest information. We also wanted to share with you a little bit of our future items that we want to take a look at, some of our time perspectives. Again, Dr. Abraham and I are not big advocates of looking at time markers and time intervals and response times and those sorts of things. But this is one area where it really does make a difference. And so what we want to look at is that 911 to first responder arrival, 911 to the transport arrival, looking at whether pre-arrival instructions were given by your dispatch agency, and then if there was any public access defibrillation prior to your arrival. So these are areas that we'll try to look at for 2018. So this is just an initial look. We hope that you become interested in being able to look at this information, measure it in your agency and the importance of looking at that in your agency, and then being able to share it and then be able to work towards the improvements that we would like to see in order to increase our survival rates of cardiac arrest in with our agencies and things like that. So with that, this is again a first look. We want you to kind of absorb this, and we'll continue to provide additional information. We'd encourage you to learn about the CARES registry and how that reporting and things are done, and then also look in your agency, what are the things that you can do to enhance your survival rates, and then again using your resources appropriately with being able to look at enhancing the number of people who learn and use CPR in your communities. And so it's great information. We appreciate the feedback. Love to hear from you what you think with this. For our transport agencies, if you'd like, we can individualize these type of programs and go over the information specific to your agency and things as well. So again, thanks, and let us know if you have any questions or any additional follow-up. Appreciate it.